to start our keynote session now. I hope you've enjoyed this last 5 minutes to just unwind a little bit before we get back into focus. I would like us all to reflect on the theme of social responsibility, healthcare conducted where people and place matter. I have the honor of introducing our student, moderator, and reflector who is joining us virtually. That is Mustafa Tukur, and we're going to watch his reflection and introduction shortly. That will be followed by the keynote itself. Thank you.
Hello everybody, my name is Mustafa. I am a fifth-year medical student at Ahmadu Bello University, Nigeria. I am currently the Vice President of the Student Network Organization. Unfortunately, this year I couldn't join you physically in Vancouver for the TUFH conference. We're still here with you virtually though, and I'll be happy to share my student reflection on the thematic discussion of social responsibility, healthcare conducted where people and place matter. To start with, social responsibility calls upon individuals to be accountable for fulfilling their civic duty to benefit society, while society also supports individuals to succeed. Social responsibility in health would refer to the individuals living a healthy lifestyle and adhering to health advice, while the community supports individuals by creating a favorable environment to remain healthy, ensuring proper hygiene, quality food production, adequate housing, and psychosocial support. The government cannot be left alone to act, bearing all responsibilities, although it cannot delegate some roles such as security, education, provision of safe water, and healthcare when needed. It needs support from individuals and communities to succeed. Social responsibility calls for a system in harmony, individuals taking an active role in the governance of their communities, and the government ensuring a space for communities to be well represented. I am made to recall a presentation by a doctor in Kenya during a conference of medical students in Africa, where he opined that the seventh component of the WHO health system's building blocks should be community engagement, to show how important it is to ensure the community participates in directing its health. It also represents the different situations that result from geographical and cultural differences, as a solution that works in one community may not work in another. We should always try and carry everyone along and leave no one behind, just as the Sustainable Development Goal number 3 advises. We all have a role to play in keeping our governments accountable to the commitments, and also think of how individually we could contribute to its achievements. We have to ensure that we do not deny some groups their rights to healthcare and advocate for greater commitment to health equity and access. There's still a large proportion of the global community that need to travel long distances to access healthcare. There are disadvantaged groups that cannot afford healthcare due to their status in society, such as migrants and refugees. Other groups require special attention, such as the aged, pregnant women, and children, which is often deficient. The development of community health workers has really made a difference in health access and improved the long-term health of the communities, especially in low and middle-income countries. They are mostly selected from the same community, have knowledge of the norms and values of that community, and live with the same community caring for them. We have to protect these health workers and find new ways to support them to continue their important work. They have been a key component of the task shifting from doctors, especially in locations where there is an inadequacy of doctors, to station to remote and rural areas. A critical component of social responsibility extends to corporate bodies, who have a social responsibility to fulfill as well. Corporate social responsibility in health includes sponsoring free health checkups for the communities, insurance cover for employees, health-compliant workplaces, and other such initiatives. In our individual ways, we could encourage healthy living. As students, we periodically organize community outreaches where we carry out basic health checks and advise the community on healthy lifestyles. The effect has been amazing, as some individuals do not get the chance for such checkups until we visit. I have always wondered how we could have a lasting solution, how the communities could adopt and sustain healthy lifestyles that would prevent diseases. That is what we're here to discuss today. I hope at the end of this session, we, the students, as well as the general participants, could have an idea about what more we could do as part of our social responsibility. To continue the discussion and dive deeper into it, I'm introducing Dr. Omaswo Francis. He is currently the Executive Director of African Center for Global Health and Social Transformation and the Chairperson of the Community Engagement Strategy Subcommittee of the National COVID-19 Task Force. Dr. Omaswo Francis is a pioneer and a reformer. He was the founding Executive Director of the Global Health Workforce Alliance, a partnership dedicated to identifying and providing solutions to the global health workforce crisis, which the Secretariat was provided for by the WHO, culminating in the first ever Global Forum on Human Resources for Health, organized under his leadership and the adoption of the Kampala Declaration and Action for Global Action, which now guides the global response on health workforce development. Before joining GHWA, he was responsible for extensive reforms in the Ministry of Health in Uganda. Through his academic career, he has served in various universities in Kenya and Uganda, trained undergraduate and postgraduate students, and mentored professionals who are now leaders in the field in the region. He was also the founding president of the College of Surgeons of East, Central, and Southern Africa, which covers 12 countries in that region. He has published in the fields of surgery and health services management, including human resources for health. At the global level, he is senior advisor to the Ministerial Leadership Initiative for Global Health, co-chair of the Global Advisory Policy Council on Health Workforce Migration, and is a member of several working groups and task forces. He has served as founding chairman of the Global Stop TB Partnership Board, chair of the Portfolio and Procurement Committee of the Global Fund Board, chair of the Gavi Independent Review Committee, and a member of the Steering Committee of High-Level Forum on Health-Related MDGs, and has been an advisor to governments on health policy and strategy in developing and developed world countries. Dr. Omaswo is a graduate of Makerere University in Uganda, a fellow of the Royal College of Surgeons of Edinburgh, founding president of the College of Surgeons of East, Central, and Southern Africa, and is a senior associate at the Johns Hopkins Bloomberg School of Public Health. He has qualifications in health services management and education as well. Please join me in welcoming Dr. Omaswo as he takes the stand to present his keynote address. Thank you very much.
Mr. Chairman, ladies and gentlemen, I am going to share with you today my reflections on how we can take a new look at the way in which we achieve better health outcomes for all the people with maximum participation of individuals, families, and communities. In particular, the message of social determinants of health, which are defined by WHO as conditions in which people are born, in which they grow, they live, and they age, and which have such huge impact on the quality of their lives and on their health. Indeed, the health systems of today are fully aware of the importance of promoting health, keeping healthy people healthy. But unfortunately, there is an imbalance in the attention to which this aspect of health systems is addressed, funded, supported, prioritized, as opposed to the effort to treat ill people. Yet, if we were really focused and serious, we should be more focused on stopping people from becoming ill in the first place. The health system should be one which is focused on keeping healthy people healthy. Some years ago, I was a Director General in the Ministry of Health in Uganda. And I recorded in my own voice a statement which was played on radios regularly, sort of something like this. Health is made at home and only repaired in health facilities when it breaks down. Please be clean. Please eat well, and do not share accommodation with animals. So this was essentially to make this point that, yes, the health system is there very much indeed to help you when you need it, but it should be more there to stop you from losing your health. The foundation of this discussion is from the fact that, most of us, only 6% of people are born with one illness or another. The vast majority, 94%, are born without congenital malformations or with the health conditions, and they can live for extended periods of time without needing health care. And our bodies are built physiologically with the ability to self-regulate, with very effective internal feedback mechanisms, ensuring that a steady state is maintained. So this message was articulated many years ago by a French physiologist, Claude Bernard, the internal environment which is maintained in a steady state by the body itself. If you need water in your body, you feel thirsty. If it is time to go to sleep, you start yawning. If you need more food in your body, you feel hungry. And so on and so on. These internal mechanisms are there, and they keep our bodies in very good condition. But the problem is that most people live their lives, they know about this, but they are not aware that it is part and parcel of their way of remaining healthy, and that they should take this phenomena of thirst, of hunger, of tiredness as very critical to the quality of their health. This message has not got home to many people, not to individuals, not to households, not to communities. And the health system of the future, I would plead, should pay more attention for this, to this question of making individuals aware that the very first responsibility for maintaining their health rests with them as individuals, as leaders of households and families, and as members of communities. So if we move on from there, we conclude that, as we move on, that the primary responsibility and ownership and accountability for maintaining uninterrupted health life rests on the shoulders of these individuals, of these households, of these families. But of course, even if you follow this, there are things which the individuals, families need from the health system and the government. The health system needs first to popularize this message, promote health literacy, awareness of people, and embedding health-seeking behavior into the population and supporting individuals to avoid unhealthy risks. For example, you find that in some communities, the easiest to access source of water is the water which will make you ill. In some communities, the food which is cheapest and most accessible is the wrong food. In some communities, like in my country, the easiest and cheapest way of transport is motorcycle taxis, which are very accident prone. So the government then is called upon through the health system to address this. And the health system should also be promoting the concept of salutogenesis. This is from Aristotle. That is creating health as opposed to causing disease, and making sure that in communities there are facilities for people to exercise. We underline the importance of social relationships, access to nature, having meaning and purpose in the lives of individuals, which together holistically address both physical and mental health. So the public health system should also take interest in the design of the physical environment where communities live. And here in Africa, a lot of people still live in rural areas. What should ideal rural homesteads look like? What are the definitions and the criteria and the standards set? Who is enforcing that these rural homesteads meet the criteria for a model home? So that is what I would be proposing the health system should be focusing on. Of course, governments are in ensuring that conditions exist which enable people to live as healthy as they can be, maintaining law and order, security, providing that safe water which I referred to before, making sure that the education system is sound, and that both personal and public health services are available. The governments the world over are struggling with this challenge of balancing between health promotion, disease prevention on the other hand, and treatment of those who lose their health on the other. But the drama of treating sick people is very powerful. An accident has occurred, somebody is bleeding, you just can't watch, you have to move. There is obstructed labor, and you can't leave that and watch. The child is convulsing from malaria, you have to do something. So in most communities and countries, it is this treating the sick people which becomes the face of the health system. So instead of calling it the Ministry of Health, many people would say, let's call it the Ministry of Disease. So we need both, but the balance needs to be right. And to get this balance right, needs visionary and strong country governments, and also the people themselves being aware of the need for this correct balance and working together with their government, with the private sector, with the civil society to ensure that the balance is right. There is, of course, also a significant role for global governance. In many African countries, we are still dependent on donor funding for our health. And we also have partners such as countries with bilateral arrangements, the UN family, global health initiatives such as Gavi and the Global Fund and so on. These are major players in ensuring that the health of the people is provided for and that social determinants are addressed. But here, my personal experience is that it is the countries which should be the determinants. If you have a well-led country health system, development partners, the UN family, the global health initiatives will find it easy to fit in. But if there is a weak country system, then it is also difficult for the partners to play their role. And then you find accusations like, oh, this is a donor-led idea and so on. It's donor-led because the country is missing in the leadership. And to me, this current debate, which is going on about decolonizing health governance, I am, in my experience, of the view that it is just up to us from developing countries to get our act together at home, and that will be the decolonization of global health. And we play our role in the global arena effectively. To conclude, we need to monitor where we are going with all this. And monitoring is extremely, extremely important so that we know where we are going. We need to be able to acquire and collect data. Data is extremely important to analyze and review this data so that we know where we are going and make adjustments accordingly in a cyclical way, and that we are, all parties are accountable for what they promised, what they committed to through that monitoring system. The monitoring also ensures that societal needs are met, no one is left behind, and that we are going in the right direction. So metrics is key to ensuring that social determinants of health with people participation is achieved. I would like to see this as a call to action by all of us. Let's examine our own personal views of this message of individual responsibility, individual social responsibility, community responsibility, working together with our governments. In Alma Ata, we were told this. We were told that health for all will be achieved through the active participation of members of their communities as a duty and a right. But are we promoting this in our countries? So time has come for us to take this route, and I would like to see more and more of this advocacy coming through. I see it. There is a friend of mine in the UK, Lord Nigel Crisp, has been writing about health is made at home, turning the world upside down. But the key message in all his writing is that let's keep healthy people healthy. Let our effort be there. And there are many others who are advocating for a movement on keeping healthy people healthy through their own active participation, which is supported by the health system and the governments. Thank you.
Hello. So I'm Bailey Ewan. I'm from the UBC Okanagan, and I just want to thank our presenter. That was a beautiful, beautiful presentation. I think you brought to light a lot of really key concerns that we can all really connect with. So does anyone have any questions?
Jan de Maasnier, former Secretary General of the Network Towards Unity for Health. Francis, thank you so much for this very inspiring talk. I think you set the scene very clear for the challenges, especially when it comes to Africa. You mentioned very correctly the role that actually still donors have in the whole financing of the healthcare system, and that is not without problems. What we have seen very often in Africa is that there is really a growth of funding for vertical disease-oriented programs like TBC, malaria, HIV/AIDS, but also nowadays for the so-called non-communicable diseases like diabetes, like cardiovascular and risks and so on. And what we see is that this is very often detrimental for the development of local primary care. We have been working now for 25 years to develop primary care and to invest in training of family doctors and nurses for primary care. And very often we have been confronted with the fact that these vertical disease-oriented programs, that this does not contribute to comprehensive primary care. So what do you think of the idea that we have launched a campaign that when donors invest in projects in Africa, for instance, that they should 30% of the resource that they invest in a vertical disease-oriented program, that should go to strengthen the local primary care setting, so that we can have the same time orientation towards a disease approach, because that will still be there, but at the same time you strengthen the development of local primary care by transferring 30% of the resources for vertical disease-oriented programs to the local primary care sector. What do you think about this proposal? Thank you.
Do I answer that, or do we have a set of questions and answer together? Okay, let me respond to that. I didn't quite get the name, but I'm sure we know each other. And thank you very much indeed for this suggestion to require the vertical programs to allocate a certain amount of their funding to primary health care. Yes, these cycles of guidelines and so on help. I would want us also to do a campaign on telling our governments to take the lead, to be the leaders. It would also help if this, like the 30% on PHC, we write it out and find a way of including it in maybe WHO guidelines or some other agency which has got some credibility and authority, because as you know, the development partners or whatever you call them who come with their money, they are a group of them who are very opinionated, and it is either their way or no money, although they still have to give the money. We also need to find a way of influencing them, influencing their thinking, guidelines for the countries, guidelines for the partners. But this idea, I buy it, because like if you have a grant for tuberculosis, for example, they may use 80% of the money for buying the TB drugs, but then the drugs don't get to the people who need them because the primary healthcare system is weak. I support your proposal.
Thank you. Is there any other questions in the audience here?
Yeah, if there are no questions, let me add to the debate on globalization.
We do have a question here for you.
Okay.
Yeah, hi, Bill Burdick from TUFH. You mentioned a couple of times the need for interaction with our country governments. I wonder if you have specific suggestions for how TUFH as a global institution, TUFH as a set of regional actors, and TUFH as a set of networks, institutions, and individuals, strategies for operationalizing that interaction with the public sector. Any thoughts on that?
Well, TUFH, of course, is a network, and the role of your partners in the countries is something which you can do more about to make them more effective, to give them additional tools which they need. And these tools include guidelines, so like this 30% idea. So I would suggest that TUFH, you get clarity. I'm one of you also. My organization is a member of TUFH. Together, let's develop some guides, like the previous question which was asked, and find ways of marketing this as a new move, a new initiative post-COVID. I think COVID has given our governments a new respect for health as a key area for investment. It has given us an opportunity to combat those who have for many years been advocating that health is a cost, that it will benefit through the trickle-down effect of economic growth. COVID has reversed all that. Thank you.
Thank you. And we have a question in the back here.
Bob Willard from Vancouver here. Dr. Maswa, I want to thank you for your lifetime of service to this point and for sharing the observations that you've gained over that way. And I wonder if I could ask you to reflect a little bit on an experience that I'd share with you. You talked at one point, I think with an extremely insightful note, that clinical medicine, the provision of care, the provision of fighting disease, if you will, tends to get very quickly prioritized, both in terms of policy and in terms of the lives of physicians. Jan de Meissner has outlined in some sense the possibility that primary care can not only provide those services, but pay attention to the determinants of health, and they're working with their communities, change those. I've had the experience both in high-resource country here, lower resource countries, of attempting to develop a cadre, educate a new cadre of primary care physicians that actually are able to live that. And the experience has been what you accurately described. And I can say this equally well from my personal experience as a clinician. And I sometimes wryly say that clinical medicine is like crack cocaine. It takes over your life. And you focus in that regard. And so what I'm wondering is, just your reflections, what could we do about that? Educationally, what could we do about that in policy? You know, you have this wonderful experience of seeing the whole system. Is there some advice you can give us as educators, as researchers, as policymakers that could not destroy that, but ensure that a proper balance is maintained in our lives and in our healthcare systems? I hope that question makes sense.
Very, very much indeed, very much. And thank you for raising it. So we have a situation where the health workforce gets divided into clinicians and public health practitioners. And that is where our problems originate from. And then we train the public health practitioners on health promotion, disease prevention, and they are weak at the clinical side of it. But then if they are primary health workers, they need both skills. And it's when they have both skills that they are at their best. And a lot of universities have courses in MPH, Master in Public Health or something of that type, which doesn't give sufficient emphasis on training these people in physiology, in pathology, in microbiology, etc., so that when they are in the primary healthcare setting, they are able to link the causes of disease, but also be able to intervene and treat those who have already got the diseases. So the practitioners that I saw here in Uganda as growing up here were that type. But now with specialization, many young people, I want to be, cardiac surgeon, something like that. And then the people who come into public health, they come from social sciences, and then they end up being the so-called public health practitioners with the communities without clinical skills. So my message, therefore, is UBC as an educator, when you run your public health training programs, include both clinical and public health skills, competencies in your trainees. And then the health system could also be built to be in such a way that those who are at the primary healthcare level are that type of practitioner. I don't know whether that makes sense.
I think that was greatly said. Thank you. And I want to encourage anyone on the chat, if they want to leave a question, we can read that as well. But we have a question over here in the corner.
Yes. So nice your talk, Doctor, because you are really adopting a scientific approach, and this is really something that is very important in terms of the messages, the key messages that you are sharing with us. I was wondering, because you were talking about what could be done with the household. I guess that it's mainly it deals with the education, particularly, but also with health systems. We know that some health systems in the African region are a lot, I would say, weakened for a lot of reasons that you know pretty well. So I was wondering that sharing actually our perspectives here in Canada, for instance, and North America and Europe, we experienced with the COVID-19 a mistrust from our population regarding our institutions, of systems in particular. Some of our citizens actually didn't believe really what we were trying to achieve in terms of health conditions, to make sure that the health and the health promotion, health prevention would be achieved. So I was wondering, from your perspective in Africa, for instance, what do you think we could think of in terms of what would be your endeavor in terms of raising this confidence in your institutions? Because my feeling is that a lot of African colleagues were telling me that the people just don't trust their health authorities or whatever. And I was wondering, to what extent, what would you propose in order to make this more, I would say, more accessible, in terms that the people could say, okay, these people are working for us, are working for the collective goods. So I would like to hear from you, because I know that you have this perspective.
Absolutely. In May this year, I was in Montreal. Dr. Tim Evans invited me to join the McGill, his school International Advisory Board. And while there, I heard that story about mistrust of the health system by people, when, believing that we deliberately design things to cause trouble for the population, make money for ourselves, and that is very serious. The disinformation campaign which we have experienced with COVID is real, and we also have it here in Africa. And the way forward for that is for us to work to ensure that our institutions are socially accountable to the people, are providing services which the people need, so that when an institution is in a location, the community around there know who is there, what they are doing, and also what they are providing to the community. And they also should become part of the governance of the institution, so that they can see for themselves what the institution is about, what it's providing to the community, and then they should be able to counter those disinformation campaigns. We should also try and investigate who are the people who are the champions of disinformation, what is their motive, and try and get to understand them better. But the real answer, the immediate answer to your question, institutions need to become socially accountable and transparent, and invite the community where they are to be part of them. That would be my simple answer to a very complex issue.
Amazing, thank you. That was greatly said. Do we have any more questions from the audience here? Then I'd like to turn it back to you, Francis, if you want to have any final thoughts or concluding thoughts.
Yeah, that's right. My final thoughts, I'll just say more about that last point. Social accountability of educational institutions and also public service institutions is extremely, extremely important. The public now has their access through the fourth industrial revolution, and they have information from all types of sources, but we have to deal with them knowing that they have their information and we have our information, and that we should be open to them so that they are part of us and not they and them. So that is one point. The second point I want to emphasize is the question of equity and partnerships. The debate is now talking about decolonization, and I don't like the word. And it is really about social justice, it's about equity, it's about partnership, and each party has a role to play. But the most critical role is for us from the South to be clear about what we want for us ourselves, and then go to the other partners with that clarity and negotiate with them from a strong position and not blame them for doing things to us. Why are they doing things to us as if we are, we are lame or crippled or something like that? And I gave you the example. My years as a Director General in Uganda, we had a terrific time with partners just because we were open and we were clear about what we wanted our health system to look like. So those are the 2 points I thought I would comment on. But the big question of keeping healthy people healthy balancing that against treating diseases. I would like to see a bigger global debate on this and a stronger movement on households themselves being informed about the hazards of sugar, about hazards of eating foods which will cause ischemic heart disease in the future, and lifestyles which do not promote health or create health. How do we create a movement around the world on that, so that in every home, people grow up knowing that they themselves have a role in remaining healthy? Thank you.